Welcome to APMA Online CECH. I'm Dr. Diane Tower, APMA Director of Clinical Affairs, and I'll be your moderator today. APMA is pleased to offer its members 3.0 Continuing Education Contact Hours, or CECH, total over a 5-week period on a variety of topics. These live webinars will be recorded and are provided complimentary exclusively for APMA members. This is week 3 of the series, and we are going to hear about the pathology, surgical, and conservative care options for juvenile hallux valgus. APMA has approved this activity for 1.0 CECH, and no commercial interest provided financial support for this continuing education activity. We will have a few minutes at the end of today's webinar to address questions, so if you have questions throughout, please type them in the questions box in the GoToWebinar toolbar. We will address as many questions as we can in our allotted time and apologize in advance if we can't get to all of them. I want to introduce our speaker and get right to the presentation. Today we have Dr. Patrick DeHeer, member of the APMA Board of Trustees. Dr. DeHeer has no relevant financial relationships related to this webinar to disclose. I'll hand it over to Dr. DeHeer.
Thank you, Diane. We're going to discuss juvenile hallux valgus in an evidence-based approach, trying to give you some information, hopefully, that you can take back to your practice and when you have that child that presents to your office with a bunion and figuring out what to do with it. I think when we get started, we should talk about the epidemiology of hallux valgus because it becomes important when we're talking about treatment. The landmark article still for juvenile hallux valgus is Coughlin's article from 1995 in Foot and Ankle International, where he took a deep dive into it. Some components from that article that I think are important take-home messages. First, the incidence and occurrence and frequency for surgical correction for juvenile hallux valgus is unknown. Footwear is likely associated with progression instead of being a cause, but there's no association with juvenile hallux valgus. Juvenile hallux valgus is reported to have high failure rates due to recurrence and considered by some ill-advised. Pes planus poses a risk factor for juvenile hallux valgus and is associated with recurrence. Other factors associated with juvenile hallux valgus and high recurrence rates are metaductus, a long first met, and a high PASA. And there's also oftentimes a positive family history associated with juvenile hallux valgus. The incidence of hallux valgus, this is an article from Journal of Foot and Ankle Research in 2010, and it looked at the pooled prevalence. And for juvenile hallux valgus, it was 7.8%, with females being about a 3-to-1 ratio to males, which is pretty common. And you see that consistently amongst the adult and elderly population. So that 7.8% is right in the ballpark with what you see with other authors. Here's an article from Journal of Foot and Ankle Surgery that also looked at the incidence of juvenile hallux valgus. This was 4.3%, so it was a little bit lower. I think that 5 to 10% range is pretty accurate. One thing that this article also shows is there's definitely a genetic component to juvenile hallux valgus. Going back to Coughlin's article, they looked at 719 bunion surgeries between 1983 and 1994. 65 of those cases were juvenile hallux valgus, so that was a 9% rate. You can just see the breakdown. Their follow-up was an average of 60 months. The average onset for the juvenile hallux valgus was 11.8 years, and the average age at surgery is 15.9 years. And that's a really important concept. We're going to get more into that timing of things, especially surgery later on. 96% of the patients with juvenile hallux valgus were related progression of the deformity, 82% related pre-op pain and symptoms with standard footwear, 24% related a history of constricting footwear. There was a high significant amount of family history for hallux valgus in the juvenile hallux valgus patients. 29 of the 31 patients had consistent maternal transmission, had a high PASA angle. And patients with a family history tended to have a worse or higher PASA and hallux valgus angle. So a couple of things with Coughlin's article. First, they did 4 different types of procedures. They did McBride, a double osteotomy, a chevron osteotomy, or a distal soft tissue procedure combined with an osteotomy. And when you look at the correction ratios for the hallux valgus angle, they were significantly better in the double osteotomy group and the distal soft tissue procedure with osteotomy group, as well as the congruency ratio, and then increase the IM angle correction as well. The outcomes subjectively were 51 excellent results, 6 good, and 3 fair. The main complications were hallux varus on 6 feet with recurrence on 6 feet also. So about 10% in each of those categories. The whole concept of metaductus associated with hallux valgus, particularly in the juvenile patient, one thing that's pretty evident as the deformity with the metaductus is more severe, the actual measurements of the IM angle, the hallux valgus angle are not quite as high as when it's a more mild deformity with the metaductus, but it also limits your correction ability because you do not have as much space between the first metatarsal and second metatarsal to correct the alignment. Long first metatarsal has also been associated with hallux valgus, and if you look at the long metatarsal subsection of this study, there were 18 cases of the 60, and they had a higher PASA angle and hallux valgus and IM angle also. The association with pes planus was found to have no significant association with preoperative deformity or postoperative failure of surgery, including over or under correction. This is an article from Kim that looked at radiographic assessment of foot alignment with juvenile hallux valgus and its relationship to flat foot. And essentially, if you look at the hindfoot x-ray views, there was no significant difference in the juvenile hallux valgus group and the control group. So there's really no correlation with that. They broke up the juvenile hallux valgus group into 2 subsections, an asymptomatic and a symptomatic group. And when you look at the radiographic parameters between those 2 groups, more specific for the hallux valgus deformity, there really wasn't much difference between those either. And their conclusion was radiographic profiles in patients with juvenile hallux valgus are inconsistent with regard to features of flat foot, and foot alignment was unrelated to the presence of symptoms or degree of deformity in juvenile hallux valgus. Another important concept from Coughlin's article is open or closed epiphysis. When the epiphysis is open, the deformity tends to be more significant. And this is one of the reasons that the recommendation has sort of evolved into waiting for the growth plate to close. And just as a reminder from Serafian, the first metatarsal-based growth plate appears about 1.6 years in females and 2.3 years in males, and closes at about 13.7 or 14 years in females and 15 or 16 years in males. Particularly when we're talking more about the Lapidus procedure, those are some important landmarks to keep in mind. Again, early onset versus late onset, the younger, the worse the deformity. So less than 10 years old versus greater than 10 years old as far as onset. I think it's important to discuss hallux valgus and its relationship to quality of life, because quality of life becomes part of the decision-making process on the treatment for hallux valgus. It's not just solely based on the degree of deformity, as you'll see. This is an article from Foot and Ankle International in 2016 that looked at patients with untreated and symptomatic hallux valgus. They had 118 symptomatic untreated HAV patients. You can see significantly more female than male. This is in adults. But if you look at the SF36 subscales, you can see the 50 marker is where the general population falls. And you can see that all of these SF36 scales were statistically significantly below that baseline for the general population. All subscales and physical component score summaries for the SF36 for untreated hallux valgus patients were significantly lower than the general population. And this is an important statement. I think that surgical decision-making should not be based on the severity of deformity alone, but whether the patient's quality of life should also be carefully assessed. And we know from other articles and how the quality of life is improved with surgical correction of hallux valgus. This is from an article by Thorson. They investigated the quality of life in hallux valgus patients undergoing corrective surgery using the SF36 scale. The authors showed that the mental subscale scores such as vitality, social function, role emotional, mental health, and general health were equal to or higher than those of the general population after they had surgical correction for their hallux valgus deformity. When we start talking about hallux valgus and correcting it, I think it's really important to understand how a bunion forms, the pathoanatomy of hallux valgus. And this is from an article in JBJS in 2011 from Pereira that really it does a really good job of going through the 10 steps of formation of hallux valgus. So step one is the medial ligaments, the medial collateral ligament, the medial sesamoidal ligament, the medial phalangeal sesamoidal ligament have to become attenuated and begin to fail. Step two, the first metatarsal moves medially over the fixed sesamoids, and that can be due to an oblique or unstable tarsal metatarsal joint that may encourage that movement. The third step is, and this is really important to remember, because the proximal phalanx is always going to follow the sesamoids, the proximal phalanx then goes into a valgus deformity. And step four, as the metatarsal head moves over the fixed sesamoids, you get erosion of the central crista. Step five is a development of a bursa along the medial aspect of the first metatarsal head. Step six, the extrinsic tendons to the hallux, so the extensor hallucis longus and flexor hallucis longus tendons, instead of becoming straight sagittal plane movers, they are now lateralized and they become deformity accentuators as they dorsiflex and plantar flex the hallux. Step seven is a very important concept. It's the first metatarsal goes into pronation. Step eight, the abductor hallucis, which is the only deformity resistor, slides more plantarly. So now it becomes more of a plantar flexor instead of a deformity resistor, which leads to step nine. The weak dorsal capsule rotates medially due to pronation of the metatarsal head, and that leads to lateral transfer of pressure. So those are the 10 steps. This whole pronation concept of the first metatarsal, the frontal plane component, it's nothing new. It's been around for a while, but Dayton has done a really good job of bringing it to the forefront. So let's talk about that a little bit more now in detail, the triplanar component. So Dayton first wrote about this in 2014, and his initial article, the take-home point was that varus rotation consistently decreased the tibial sesamoid position, and that frontal plane rotation of the first ray is required for complete anatomic correction of hallux valgus. And one of the studies that Dayton did later that year is they took cadavers and they rotated just in the frontal plane from 30 degrees valgus to 30 degrees varus. And if you look at the tibial sesamoid position on the far left under the 30-degree valgus column, you'll see they're around 5. And just with frontal plane rotation only, no transverse plane movement, to 30 degrees varus, they basically go down to 1. And that shows you the correction that was obtained with just rotation in the frontal plane. Here is the picture. It's important to start incorporating tibial or axial sesamoid views in your pre and post-operative evaluation for hallux valgus, but our goal has got to be able to take those rotated sesamoids and put them back under the metatarsal head and get the metatarsal back where it belongs, because that's going to give us the long-term results that we're trying to achieve and reduce the recurrence rates. How much rotation did it require? Well, Dayton found that it was about 22 degrees. And there are people out there who still want to argue that translational osteotomies like Austin bunionectomies or Z bunionectomies, for example, you can wedge them and move them and manipulate them to rotate in the frontal plane, but there's no way that you can rotate a translational osteotomy 22 degrees in the frontal plane to correct that pronation of the first metatarsal and sesamoid position. Kim also looked at this. I really like it when I see multiple authors coming to the same conclusion. I find that reassuring. So Kim had a control group, hallux valgus. They used partial weight bearing CTs to evaluate the pronation of the first metatarsal and the sesamoid subluxation. And Kim found in the hallux valgus group 22 degrees, which is identical to what Dayton found of pronation of the first metatarsal, compared to the control group, which is about 14 degrees. And that difference of about 8 degrees is important because you see that in multiple articles that have come out even after this Kim article, where that relationship between controls or normal or post-operative realignment compared to preoperative realignment is always about an 8-degree to 9-degree difference in pronation of the first metatarsal. So that's a consistent theme throughout the emerging literature from this Kim article. Kim basically described 4 types of hallux valgus. First, and you can see the definition, first metatarsal is considered pronated if it was more than 15.8 degrees on the alpha angle, and the CT 4 position was greater than equal to 1 for the sesamoids. So One was no pronation of the first metatarsal, no subluxation of the sesamoids. That's what I would classify as a mild bunion deformity. 2 is no pronation of the metatarsal head, but there is subluxation of the sesamoids. 3 is what they call pseudosubluxation, where the metatarsal is pronated. The sesamoids look like they're subluxed, but they're really not. They're still beneath the metatarsal head just because the metatarsal is pronated. So they call that pseudosubluxation. So in my mind, I think of 2 and 3 as the moderate type deformities. And then 4, you have both pronation and subluxation of the sesamoids. How often is the first metatarsal pronated? What Kim found was 87%. So if you want to do a translational osteotomy, that's fine. If you don't believe in the concept, that's fine. But guess what? You're going to get it right 13% of the time. That's just a fact. The other thing that Kim found too is that 72% of the time the sesamoids were subluxed. And remember, because the hallux follows the sesamoids, if the sesamoids remain subluxed, eventually the hallux is going to go back into valgus. And it's interesting because the Austen bunionectomy is by far the most common bunion surgery, and it's been around since the early 1970s. So it's been around for 50 years, and the longest long-term follow-up for the Austen bunionectomy is 7.9 years, and hallux valgus recurrence is defined by a hallux valgus angle greater than 15, and the recurrence rate in the study was identical to the amount of sesamoid subluxation that Kim found. So it's 72% or 73% here. Kim showed 72% of the time the sesamoids are subluxed. That makes sense. They should be the same. If all of this is actually true about frontal plane and rotation, then those and sesamoid subluxation, those numbers should be the same, and they are the same, which is reassuring. Other authors have looked at this. Campbell came out in 2018 and looked at the rotation within the proximal phalanx of the hallux and the first metatarsal. Again, if you look at the pronation number, it's 27 degrees, which is a little bit higher than what Kim and Dayton showed. But if you look at the difference between the control group and the hallux valgus group, we still see that 8 to 9 number difference between normal and hallux valgus. There was no relationship between the pronation of the great toe and the metatarsal and the first metatarsal in the hallux valgus group. And some people who don't believe in this concept of frontal plane rotation like to use this as an argument. They're wrong. There really should not be a relationship. The hallux is going to be related to the sesamoid position, and the first metatarsal pronation is independent of that. And they're not going to be the same. So they're both a component of the deformity. And there was an article subsequent to this that Conti put out in 2019. I haven't added to this lecture, but he showed similar results in the amount of hallux or first metatarsal pronation and the difference between their pre-op metatarsal pronation and the post-op metatarsal pronation are pretty much identical to what this Campbell study shows. Chiotes and Foot and Ankle International looked at this pronation of the first metatarsal in relationship to foot deformities, and basically they showed the hallux valgus deformity demonstrated significantly higher pronation of the first metatarsal, and it was even worse compared to controls, and that was even higher in patients that had a pronated foot type. So as the foot pronates, the first metatarsal elevates in the sagittal plane, but it's more of a triplanar deformity that occurs, so the pronation becomes worse in a pronated foot structure. Meyer has looked at this and was the first really to link all three planes together. There's some conflicting literature. Not everything's been answered on this yet, and there is a little bit of conflicting literature. The Conti article that I mentioned from Foot and Ankle International in 2019 and this article actually don't agree, but Meyer looked at the relationship between all three planes and showed a consistent, statistically significant correlation that as the transverse plane deformity of the first metatarsal and hallux phalanges increased, the frontal plane deformity of the sesamoids also tended to increase, and the first metatarsal inclination angle tended to decrease, or the first metatarsal elevated. And that, I think, just inherently makes sense because that's what we see every day when we're looking at bunion deformities. And the evaluation of the deformity with emphasis on all three planes is really required. The question is, though, what if this is not all a rotational problem, that there's an actual torsional component to this? Part of that pronation of the first metatarsal is not just rotation, but there's actual twist within the bone. There's over 140 bunion surgeries or variations of bunion surgeries described in the literature. And we're going to talk about how this paradigm shift has really reduced that number to maybe 5 or 6 applicable procedures, in my opinion. But this component's really important because if there is truly a torsional deformity within the first metatarsal, there's an actual twist that's part of this. Selecting a procedure that untwists the bone, I think, becomes really important. So ODA looked at this. They compared the base of the first metatarsal and the distal aspect in both controls and hallux valgus, and they showed a significant difference of 4.7 degrees of torsion in the control group and almost 18 degrees in the hallux valgus. So not only was the metatarsal rotated, but it was also twisted, is what they were saying. And this twist, what they found, was occurring between the proximal 2/3 distal 1/3 junction of the first metatarsals where the twist was actually occurring. So if you look at this picture on the right from the article, you can see in the control group, the metatarsal heads were all aligned in relation to the bases. In the hallux valgus, there is a twist within the distal aspect, so the distal aspect of the metatarsal head was rotated relative to the base. They basically couldn't identify, is this something that people are born with, this torsional deformity in the first metatarsal, or is it something that is developmental due to foot function? And that question hasn't been answered yet. But if this component, if this overall pronation of the first metatarsal is both a rotational problem and a torsional problem, then addressing both, I think, becomes important as far as procedure selection for long-term outcomes. So what about the role of hypermobility in hallux valgus? Rukas and his group did this article in JFAS in 2017 where they did a meta-analysis. They looked at articles that had been published that compared first ray range of motion in patients that had hallux valgus deformity compared to controls. And basically what they found was that 3.6 more millimeters of motion was occurring in the first ray for hallux valgus patients compared to control groups, but there was a lot of heterogeneity amongst those studies. And when they adjusted the heterogeneity, it went down to 2.94, or let's just say 3 millimeters more motion compared to controls, which is still statistically significant. In their conclusion, they said the Lapidus procedures has become a very popular option for hallux valgus, but is it really required to deal with this hypermobility? Because several studies, and we'll go over some of these in a second, have shown just segmental realignment or realignment of the first ray provides stability to the medial column of the foot, and that you can provide restoration without arthrodesis. One of those studies is from Kimura JBJS in 2018, and they looked at first ray range of motion. The thing that's important to remember is, let's just go back to that number of 3.0 millimeters or 2.94 millimeters more motion in the hallux valgus group. Not all of that motion is occurring at the first metatarsal cuneiform joint. It's occurring at the navicular cuneiform joint and the talonavicular joint. And if you look at some of Christensen's work, he actually showed more is occurring at the navicular cuneiform joint than any of the other two joints. So that 3 millimeters of motion is being distributed amongst those joints, with the most being at the navicular cuneiform joint. So how much is actually occurring at the first met cuneiform joint is debatable. And is the amount that is occurring at the first met cuneiform joint then statistically significant enough to have to address? That is a question. Coughlin also looked at this, and Coughlin showed preoperatively first ray mobility was 11 millimeters. And when they just did an osteotomy, a proximal crescentic osteotomy and a distal soft tissue procedure to realign the first ray, the postoperative mobility went down to 5.2 millimeters of motion, so it decreased by 5.8 millimeters, which is statistically significant. And just this concept of segmental realignment providing stability to the first ray is an important one. And Coughlin thought that there were extrinsic anatomic features that play a role in first ray mobility. I think this article kind of ties all this together really nicely. This is a study that they did either a Homan osteotomy or a Lapidus osteotomy for hallux valgus patients. And they looked at AOFAS, VAS, and then IM angle and hallux valgus angle. And this had an 8 to 11 year follow-up. So this had a long-term follow-up in the study. They also had a subset of patients that were considered hypermobile in each group. So a subsection of patients that received the Homan osteotomy and a subsection that received the Lapidus. And essentially, looking at the outcome measurements and the radiographic findings, there was no difference between the two groups, or specifically the subgroup of hypermobility patients in either procedure group. And so the conclusion from the study in the Bone and Joint Journal in 2013 said it does not support the theory that hallux valgus deformity in a patient with clinically assessed hypermobile first cuneiform joint requires arthrodesis. So is the deformity apex or the cora of the deformity actually at the metcuneiform? And aren't we supposed to correct deformities at the cora? So that's an important question to answer when we're talking about this. Just a quick reminder, the mechanical axis of a bone is the center point of the proximal joint that bone makes, and the distal joint that bone makes. So it's the center point of those two points. The anatomical axis is just the bisection of the bone. The mechanical axis is much more important than the anatomical axis. If you're in a car wreck and you have you break your femur and it heals in an S, as long as your hip and knee are aligned in a straight line, you're going to function normally. The anatomical axis is not quite as important. And ideally, yes, we correct deformities at the core or at their apex, so we do not have any angulation or translation that occurs. So Laporta looked at this. He defined the mechanical axis of the medial column and the first ray, and in a normal foot those are collinear. He also defined the mechanical axis of the second ray, and that first ray to second ray mechanical axis is consistently 11 degrees, and there have been other studies that have confirmed this finding because they're based off the proximal phalanx of the hallux in the second toe. And remember, because the proximal phalanx follows the sesamoids and the sesamoids don't move, the metatarsal is what moves, that number is going to be consistent. Now, when you have a hallux valgus deformity, there's a third line, which in this picture is line BD. And that is where you get your difference between the two lines BD and AE. And where they cross is point D, which has been defined, which Laporta defines as the cora of hallux valgus. So it's the proximal lateral first cuneiform. And there are no procedures that correct at the proximal lateral first cuneiform. So any bunion surgery that you choose, even a lapidus, is going to require some amount of angulation and translation. So you're not correcting the deformity at the cora. So let's talk about hallux valgus and juvenile hallux valgus and conservative treatment. And the one thing that always comes up are orthotics. So there's not a ton of literature on it. There's one article. We're actually working on a meta-analysis on this topic. It's not going to be specific for juvenile hallux valgus, but we're looking at the research on orthotics and changes in the IM angle or hallux valgus angle. But this Kilmartin article in JBJS British Journal in 1994, they screened 6,000 children between 9 and 10 years of age. They had a HAV incidence of 2%. They had a randomization of treatment. So one group received a functional orthotic, the other group did not receive any treatment. They followed them every 6 months for 3 to 4 years. They used radiographic parameters, the hallux valgus angle and IM angle. They lost a few patients to follow up, as you would expect. They were not able to standardize footwear, but they did not consider that to be a co-founder. And 3 years after the initial exam, the children were x-rayed again to look at those angles. So first, in the bilateral hallux group, there was no significant difference between the study group that was treated with orthotics and the control group that had no treatment with orthotics. The deformities progressed in both groups at a similar rate, so no difference of that. In a unilateral hallux group, if you look at the hallux valgus angle, actually it got worse on the unaffected side at a higher rate for the study group and the control group on the unaffected side. There's no difference in the IM angle. So their conclusion from the Kilmartin study was the biomechanical orthoses of the type we use, which they describe as functional, and some people who don't like this article question what that really means, but they say it's a functional orthotic in the article, and it should not be used to treat juvenile hallux valgus. They appear to increase the rate at which the condition progresses. In children with unilateral hallux valgus, the orthoses do not halt the development of hallux valgus in a clinically normal foot either. So I know this goes against a lot of sacred cows in our profession regarding orthotics and treatment for juvenile hallux valgus, but until somebody else can produce research that supports use, this is the one article that uses radiographic measurements to show that the deformity still progresses, and in the unaffected side, in the unilateral hallux valgus patients, it actually got worse. So what of our surgical treatments now? I talked about previously the 140 or so plus different options to treat hallux valgus surgically or variations of procedures. When you take the new paradigm shift with the frontal plane into consideration, I think we can knock it down to about 6. So distally, you're talking about a Homan or Wilson osteotomy, a Siri or Bosch, which is basically a minimal incision Homan type procedure. And I want to take just a second to discuss minimal incision procedures. Not all MIS bunion surgeries are the same. Some MIS distal osteotomies are basically Austin bunionectomies or chevron type osteotomies. They are translational. They are not going to allow for triplanar correction. So a triplanar correction can be accomplished with a Homan type osteotomy. And the third would be a Mitchell osteotomy. Proximally, you're talking about a crescentic or crescentic-like osteotomy. That's about all that allows for correction in all 3 planes. And then you have your arthrodesis procedures, whether it's a Lapidus or a first MPJ arthrodesis. As far as talking about juvenile hallux valgus and our treatment options for those surgically, one consideration is the opening wedge, medial proximal opening wedge osteotomy for correction. And Iyer looked at this in Foot and Ankle International. It's 17 patients. This was not all just children. This was also done in adults, but it had a significant recurrence rate. And they basically abandoned that procedure in favor of a Lapidus procedure due to much lower recurrence rates. So both the hallux valgus angle, the IM angle, and the PASA went up with time. And I've had some experience with opening proximal medial opening wedge osteotomy. So here's a pediatric hallux valgus. The growth plate's just starting to close at the first metatarsal base. I maybe could have waited another 6 months to a year to let it fully close, but we went ahead and I did an opening wedge, and with this is back when I was doing subtalar arthroresis more frequently, but I wasn't super happy with the correction with this, so I took her back in, did an Austin bunionectomy to try to get better realignment of the distal aspect and the hallux valgus angle, specifically as far as getting the sesamoids back into position, and even that, there was recurrence down the line with the hallux valgus deformity, and I think that's not surgeon error. I think that's just inherent for those procedures. They're just not, they do not allow for triplanar correction, hence the recurrence. And you can see the sesamoids went back into a valgus position. I don't have a sesamoid view on this, but you can see they went back, the metatarsal is back over the top of them. And the phalanx is going to follow the sesamoid. So if the sesamoids are not aligned under the first metatarsal, the proximal phalanx is going to follow them and go back into valgus. Another option for juvenile hallux valgus is a lateral hemiepiphysiodesis, which that's a tongue twister for me. But essentially, you're closing down the lateral portion of the proximal physis on the first metatarsal. And this is indicated in girls up to 10 years of age and boys up to 12. You need at least 2 more years of growth as recommended with this. And essentially, how you treat this is how you do this procedure is you just put a K-wire in through the growth plate, then you're going to drill cannulated drill bit through there, and you want to ablate up to about 25% of the lateral portion of the epiphysis. Problem with this is really, if you look at the data from the study, the amount of correction was pretty minimal. I mean, usually the IM angle should be between 8 and 10. The hallux valgus needs to be lower than 15. You can see the results in this were not very good long term. Lapidus has also been studied in the pediatric patient for hallux valgus. This is an older article, but I think it does have some valuable information to it. So this had a follow-up of 61 months with 23 patients, 30 feet. Average age was 16.5 years. And 25 excellent results, 3 good, 2 fair. There were 2 recurrences and 1 non-union. The author's conclusion from this article from Journal of Foot and Ankle Surgery was the Lapidus restores stability of the first ray to eliminate disturbances in weight-bearing patterns of the forefoot, and it eliminates multiplanar instability. This is well before we really understood the triplanar component, but they even kind of danced around that in their conclusion by saying it eliminates this multiplanar instability. So thinking of bunions in more than one plane. I think Lapidus is probably the best choice in hallux valgus for the juvenile hallux valgus patient once the growth plate is closed. So here's a case. I usually will treat concomitant deformities as well. So if there's a pediatric flat foot associated with a juvenile hallux valgus, I'm going to treat that as well as usually any underlying equinus deformity. So here's a patient. She was 14 years old. You can see a pretty significant bunion deformity for a 14-year-old. The growth plate's closed at the proximal aspect. I took her in. I did a Baumann gastric recession, an Evans osteotomy, and then a Lapidus. And you can see, if you look at the distal aspect of the first MPJ, you can see the sesamoids are centered right where they should be. The joints straight ahead. Also, it's important to look at the lateral aspect of the first metatarsal. When you have a deformity, hallux valgus deformity, you'll see a rounding of the lateral aspect of the first metatarsal because that's actually the plantar condyle that you're seeing. And when you fully derotate, and this is an important thing to look for intraoperatively when you're using C-arm fluoroscopy, you should see that lateral aspect squaring off. If you take a first metatarsal out of a cadaver and you look at it from the front, the lateral aspect of the first metatarsal is not rounded, it's squared off. What you're seeing as far as the rounding is concerned on C-arm or X-ray is that plantar lateral condyle due to the rotation of the metatarsal. So here you can see the correction in the sagittal plane for the flat foot deformity with the Evans. Lapidus also will help stabilize the medial column of the foot and the overall arch. She also had a Baumann with this as well. I do think that there is some potential for the Siri or Bosch procedure, which is that minimal incision Homan type procedure. This is an article from Foot and Ankle Surgery 2017, where they use the Siri procedure for mild to moderate juvenile hallux valgus. I'm not sure why they use the term juvenile only, because the age group was from 16 to 30, so it actually got into adults also, but they had a 1-year follow-up, and you can see part of their patients received MIS Homan, part of them received a chevron osteotomy. Both groups had pin fixation that was removed at 6 weeks post-op. The operative time and incision length was significantly different between the two groups. The preoperative radiographic parameters there's no significant difference, so the severity of deformity was similar between both groups. The overall postoperative outcome measurements and range of motion was not significantly different between the two groups. However, the satisfaction rates were, the MIS group had a satisfaction rate of 88%. The chevron group had a satisfaction rate of 66%. One of the things, if you look at some of the x-rays from the study, is you can tell they did not do any kind of frontal plane correction, and they didn't describe it when they described the technique. So they did the Siri procedure, but they were not derotating in the frontal plane. Especially if you look over on E, you can see the sesamoids are still a little bit lateralized on that x-ray, and there's rounding of the lateral distal aspect of the first metatarsal group. One of the things about the Siri procedure, and I would agree with the statement from the article, is you can have pain at the osteotomy site for about 4 to 6 months afterwards, just from the natural remodeling of the bone that's occurring where that osteotomy is done. This is a patient, another pediatric patient. She was about 16 years old or so in high school with kind of a mild flat foot, but it was probably more of a transverse plane deformity than sagittal plane flat foot, and then a hallux valgus that was symptomatic. So I took her in and did my sort of standard approach with a Baumann, Evans, and a Lapidus. And initially I thought, okay, this looks pretty good. I was pretty satisfied with the results, and you can see the sesamoids look like they're well positioned. The hallux looks rectus on the metatarsal. The lateral aspect of the first metatarsal head is squared off. So I'm, going along thinking things are going well. And then I start seeing this recurrence with the hallux going back into valgus over a period of months. I have a study that's being published that looked at the removal rate for Evans hardware, specific hardware, due to perineal tendonitis, and it's about 31%. So she started developing some perineal tendonitis, and I was going to have to take her in and take the perineal, or to take the Evans plate out to help alleviate the perineal tendonitis that she's having from irritation due to the hardware. And I discussed with her and her parents about sort of tweaking the bunion surgery, or to just fine tune it, I think is a better term I use a lot when I'm discussing a revisional type procedure with us, and doing the CECH procedure and just leaving the hardware in for the Lapidus when I take out the Evans plate. And that's what I ended up doing on her. And so you can see here, I've did the CECH procedure with, I use 2-pin fixation for it. The medial pin is a 2mm double-ended 9-inch Steinman pin. The other pin, and that is what locks in the transverse plane and the frontal plane. The other pin is a 6'2" K-wire, which when I first started doing them, I wasn't using that second pin. I was seeing a little bit of sagittal plane movement with the distal capital fragment. But I started adding that second pin, and that helped eliminate that. That sort of locks in the sagittal plane, and you can see the sesamoids are where they belong. The lateral side's rounded, is squared off now, no longer rounded, and there's good alignment of the joint. And this is a little bit further down the line with healing. And that lateral aspect fills in with bone. The medial side will remodel with time, so it's not prominent. And again, the mechanical, if you look at the mechanical axis of where the first metcuneiform joint would be if it wasn't removed, or you can go to the first navicula joint if you'd like, to the distal aspect of the first metatarsal, that's a straight line. The anatomical axis has kind of an S shape to it. That's not what's important. The mechanical axis is what's important. You can see good alignment in the sagittal plane of the arch and no elevation of the distal fragment of the first metatarsal on the lateral view. I ended up doing her other foot. Her other foot, the bunion was not as severe, so I just did the Evans gastroc recession with a Baumann type procedure. And I just did the CECH procedure on the other foot without doing the Lapidus, and she did quite well with that. This is what that showed in healing. So my recommendations for juvenile hallux valgus: first, wait till if you're going to do surgery on these, first wait till the first metatarsal base epiphysis is closed. You're just going to have better results. The deformity is not going to be as severe as it would be otherwise, assuming that they meet the criteria for surgery. I am a big principles person, so the principles for hallux valgus correction for me are the procedure has to have triplanar correction. I'd prefer to do something extra-articular versus intra-articular for range of motion purposes, and it's important to preserve the blood supply to the first metatarsal head. I've had patients that developed AVN of the first metatarsal head after an Austin over a 30-year period of time of doing bunion surgery, and it is a devastating problem to deal with. So that lateral nutrient artery is very important, and it's certainly at risk with an Austin osteotomy. I also recommend correcting other deformities at the same time. So if they have a flat foot, I'm usually going to be doing an Evans as well. And if they have Aquinas, I'm be doing a Baumann gastroc type recession. So those are my recommendations for juvenile hallux valgus. I think the tricky thing is the conservative care and orthotics. If you want to use orthotics, if they have a flat foot and you want to treat the pediatric flat foot with the orthotics, that's fine. But I don't think you can really expect any improvement or prevention of progression of the hallux valgus, the juvenile hallux valgus deformity with the orthotic therapy. Understand that they're just not going to help the bunion component of it, but if you want to treat the flat foot part of it with the orthotics, that's fine. And I think you need to explain that to the patient and the patient's parents when you're discussing orthotic therapy. So I'll open it up for questions now. Also, if you would like a PDF of this lecture, if you just hold your phone up to this QR code, it will send you a link to my Google Drive that you can download the PDF of this lecture.
Thanks so much, Dr. DeHeer. And the PDF lecture is also in the handouts tab of the GoToWebinar toolbox if you'd like to download it there. And it's also online at www.apma.org/online CECH under week 3. Thanks again, Dr. DeHeer, for all the information. We do have a few minutes for Q&A, and before our first question, I'll note that the link to the evaluation for today's webinar has been shared in that questions toolbox in the GoToWebinar toolbar. It will also be shared with attendees via email later today. You must complete the evaluation in order to be eligible for CECH, and you will have through May 24th to complete the evaluation for this webinar. Certificates will be sent via email to the address you used to register for today's event within 2 to 3 weeks of today's webinar. We do have a few questions, Dr. DeHeer, and I'll start with one that's asking, how do you discuss potential recurrence with parents if we don't address the proximal deformities like a lapidus, given the lack of statute of limitations when the patient is under 18?
Mm-hmm. Well, I mean, I think recurrence is a standard complication. I don't consider that anything that's, has been done wrong. It's just the reality of the procedure, and that should be in the discussion of the potential things, complications that can occur with that procedure. I do think it's important to choose a procedure that provides triplanar correction so that you're going to have lower potential for recurrence. And if you have recurrence, I think it's just being honest with the patient's parents and the patient when you notice the recurrence, and you can discuss with them whether they want to do anything about it or not, because you don't have to just kind of put your head in the sand and act like, oh, pretend it didn't happen, because things happen, and it might need fine-tuned. I really like that terminology when I'm discussing like tweaking procedures. It doesn't matter what it is, where there maybe you haven't got the ideal alignment or correction that you want, and you may have to go in and fine-tune that procedure a little bit.
Thank you. We've got a couple of questions that are about surgery in particular, so there might be a few as part of this series of questions, but what is the earliest age you would consider surgical intervention?
So it's hard to say a specific age, but you want the proximal growth plate closed. And for girls, that's going to be around 14, and for boys, it's around 16. Those are just general numbers, but it's really based on x-ray. That first lapidus case I showed, I saw the patient when she was about 12, and I monitored her. She was in orthotics for her flat foot, and I was monitoring her. When I have a pediatric patient in orthotics, I usually check them every 6 months, and we were watching her growth plate for it to close before we decided to take her in to do surgery, and it was right about her 14th birthday.
And it sounds like those same parameters are whether you're doing a fusion or something that's not a fusion.
Correct.
Okay. Wonderful. Thank you. Do you ever fuse intertarsal joints with your lapidus to reduce recurrence?
So I am not great about checking for first ray to central ray instability as much as I should intraoperatively with lapidus. I think that that's more of a problem with adults than children. When I do notice it, or if I have a revision, like I have a non-union from a lapidus, I will run a first met base to second met base screw to lock in the medial column of the foot to the central column of the foot. It improves construct stiffness. And Dayton did a study where they looked at the different options of stabilizing the medial column of the foot to the central column of the foot, and he found that that first met to second met screw was the most effective way, as versus like going intercuneiform or first met into second cuneiform alignment for the screw positions.
And keeping on with the surgical questions, do you always do a lateral release?
So usually not, actually. If the metatarsal, so for younger kids, I don't think you have to do a lateral release. I think in older patients sometimes you do, but it's pretty rare. I do think the one thing that I've tried to pay attention on is when I've done a lapidus, like that one case where I had the revision and do the Siri procedure, the roundness of the metatarsal head, I think, is something to look at, and that might require a reason to do do a lateral release, but I'm really careful when I'm doing a lapidus. I really take my time. I slow down a lot when I'm trying to get the position. I'm trying to get all three planes corrected. I really try to be diligent about that. But even with that, you can still get recurrence. And I think it's really important to be happy with the position on the table and not try to talk yourself into it. Well, we can splint it or whatever afterwards. If you do your lapidus and you've really worked hard to get all three planes aligned and you still have some lateral deviation or valgus positioning of the hallux, I think going in and doing a lateral release would absolutely be indicated at that point.
And Dr. DeHeer, how do you feel about Lapiplasty procedure, triplane, and fusion?
Well, you can do a triplanar correction without any fancy instrumentation. I just use 2K wires. I'll take a 6-2K wire and put it in at the center point of the joint of the first cuneiform and the first metatarsal, and I just rotate it, and that kind of tells me that I've how much rotation I've achieved. Really, what's important is you can do it without all the fancy equipment. Is to really look at it with C-arm fluoroscopy, looking at the distal metatarsal head, looking for the sesamoids to be positioned, looking for squaring off of the lateral aspect of the first metatarsal. When you achieve that and you can see it on the C-arm, you know you have the deformity fully corrected. I don't think you need anything extra or special to accomplish that.
And is there a difference in weight-bearing restriction in pediatric Lapidus patients versus adults?
That's a good question. If we're talking about just a straight lapidus, no. For me, if I'm just doing a straight lapidus, it's 2 weeks non-weight bearing. Then I put patients protected weight bearing in a boot. I call that assisted weight bearing. The thing that's driving the bus a lot of the times for me on the post-operative course is the Evans. So I tend to have patients non-weight bearing for 4 weeks with my Evans procedures. And so that's usually more than I would with the lapidus, and then they are weight bearing with a boot. I usually on peds, I'll keep them in a boot, so they'll go 4 weeks non-weight bearing, and then four to 6 weeks more weight bearing with just the boot on, depending on radiographic healing.
And does your protocol for non-weight bearing change if the CECH procedure is done as well?
So if it's just a CECH procedure, they can bear weight on it normally. So my normal protocol for a CECH with no other procedures is they can walk on it from day one with a boot. They're in a boot for a total of 6 weeks. I take those pins out in the office at week 4, and then after 6 weeks, they can go into a shoe. Now, a lot of times in the juvenile hallux valgus patient, you're also doing an Evans, so you're going to be non-weight bearing for that. But in those cases where it's just the CECH procedure, they can be immediately weight bearing post-operatively.
Great. Do you consider removing Lapidus hardware?
I only take hardware out if it's symptomatic. I don't have to take Lapidus hardware out very often. The Evans is a different story. Like I said, we published that. That's going to be in JAPMA pretty soon. That article, I think, is actually going to be in the next issue of JAPMA.
Thank you. Can you describe what the Baumann procedure is?
Sure. So it's a gastroc recession. You're working at the muscular level, and it's an intramuscular fascial lengthening. It's not an aponeurotic lengthening. A Strayer is lengthening the aponeurosis, but a Baumann's a little bit higher, and you're doing an intramuscular fascial lengthening. The reason the Baumann is becoming the preferred method is you do not get the weakness that a Strayer causes, and that's just because of the level that you're working. The good thing about both those procedures is that neither one of them are going to allow for overcorrection. You can't cause a calcaneal gait deformity like you can with a TAL. So you eliminate that severe complication that can occur with a TAL. But with a Baumann, you're not going to get the weakness that is really more noticed with going up and down stairs, running, jumping. I mean, if you're doing a pediatric bunion case, you don't know if that child's going to be a college basketball player or a college volleyball player or a track person or a cross country. So why create weakness in the posterior muscle complex when you don't have to? So the Baumann is fast becoming the procedure of choice to lengthen the posterior muscle compartment.
And the next question, Dr. DeHeer, is how do you treat a 3-year-old with early lateral deviation of the hallux?
So if you have a kid that young, they're probably going to have an associated flat foot deformity. I would definitely put them in orthotics, understanding that that's for the flat foot deformity, not the bunion, and treat that until they, become skeletally mature. And I watch kids every 6 months when I'm treating them for a pediatric flat foot with orthotics conservatively, and you can monitor the bunion during that time period. One thing I will say on children, probably not quite that young, but let's say the 8-year-old with a flat foot, oftentimes they have an associated equinus deformity, and we know the compensation for equinus is through the navicular cuneiform joint. The equinus drives the navicular cuneiform joint down through the sagittal plane. And if you have the gastroaxilleal complex flattening the arch to the NC joint and an orthotic pushing the arch up, they're fighting against each other, and the battleground's the foot. If you stretch out those kids first, I always tell patients, parents, that it's a two-step process. We're going to stretch them first to remove that deforming force of the leg onto the foot. Then the foot can accept the orthotic control that it requires without fighting against the gastroc soli or gastroc equinus.
And what is your criteria for doing the Evans versus the arthroresis?
I used to do a fair amount of arthroresis, and it became an insurance problem. They just aren't covered very much anymore. The one thing that I've grown to really like after doing a lot of Evans procedures is, I think, structural. And if you look at the literature on posterior tibial tendon dysfunction, especially the flexible, like stage 2, structural realignment is really important. And I really think that with an Evans, you achieve structural realignment better than with a subtalar arthroresis. I know that some people would want to argue that, but there's a robust amount of literature on the Evans procedure. It's a triplanar correction of the hind foot. But I think the key is that you've got to correct each level of deformity. You've got to remove any deforming force of the leg onto the foot, so that's dealing with equinus. You have to get the hind foot perpendicular to the ground, and there's a ton of literature on that, particularly in the adult flexible flat foot. And then you've got to have the forefoot parallel to the rear foot, and so that there's no forefoot varus deformity. And if you can achieve those three things, and it doesn't really matter how you accomplish them, but those are the goals that you've got to achieve. Those are the principles you've got to follow to have optimal outcomes.
And we've received a couple more questions about the Bauman's procedure. What's the risk of sural nerve issues associated with that, and what is the post-op course like?
So there's no risk for sural nerve injury because you're going in between the muscles. You're right between them, so you have the whole soleus muscle behind it. Now, with a Strayer procedure, the sural nerve risk of injury is 13%. That's been well documented in the literature, but there isn't any with the Bauman procedure. If I'm just doing a Bauman procedure, like for chronic refractory plantar fasciitis, it's actually a really minor postoperative course. It's full weight bearing in a walking boot for 2 weeks, and then they go into a shoe. I just ask them to do no running or jumping up to week 6. So for the next 4 weeks, no running or jumping. Then after 6 weeks, they have no restrictions.
And what angle would you go up? What IM angle would you go up to with the Siri procedure?
That's a good question. It's really where you would kind of use an Austin bunionectomy. 15, 16, at 16 might be pushing the limits on it, but it's definitely for the more moderate type deformity. I wouldn't go much more than 15 or so.
And it looks like our final question is going to be, why are we calling it a juvenile bunion if the epiphysis is closed?
Well, because the other physes are still open, I think, and the rest of the part of the foot, and they haven't reached full skeletal maturity, just it has in that one part of that one bone. So I think that the term's applicable.
Great. I want to thank you all for joining us today. Dr. DeHeer, thank you so much for sharing with us week 3 of the APMA online CECH series. We hope you'll join us next week, Thursday, May 21st at 8 o'clock in the evening, Eastern time, 8 p.m. Eastern, as Dr. John Goldsmith discusses medial double arthrodesis and flat foot reconstruction. Check out www.apma.org/online CECH for the most up-to-date details on the series. Thank you all and have a great day.
Thank you.